So I'm delighted to welcome onto CVCT Cardio Brief blog, Professor John Teerlink from UCSF. I'm a long-standing fan of for his research in heart failure. And today he's going to talk to us about omecamtiv, a new clinical agent for heart failure, and the Galactic-HF trial, which presented results of this. So John, welcome.
Darrel, it's great to have an opportunity to join you on the CVCT blog, so it's great.
Fantastic. The unique thing about this drug is it isn't a thing that stimulates the renin-angiotensin system or any kind of diuretic. It works somehow on the myocytes internally. And we've obviously had a lot of drugs in the past that have worked directly in the myocytes internally that have looked good on the day and then have looked a lot less good down the line, the inotropes. So could you help us understand what's unique about omecamtiv?
Well, I think you've hit on a very good thing and also tried to avoid using that dirty word of inotrope.
Oh, yes.
But we all have to eventually fall upon it, which is why actually some really nice work by Mitch Sotka and crew in a publication in JACC did this nice outline of kind of looking at agents that improve cardiac performance in three different groups. The one group, which are the calcitropes, which improve cardiac function through influencing calcium fluxes. And these are all the bad actors that we know about, the dobutamine, milrinone, and enoxaparin, all of those.
Kilrinone, as I like to call it.
I actually was going to go there as well, but
okay.
The second group are the mitotropes, and mitotropes are the agents that improve cardiac performance by improving the energetics of the cardiomyocyte. So these are things like perhexylene, trimetazidine, ranolazine, and then other agents that are in investigation. Maybe even the SGLT2 inhibitors might actually fall into that group.
But do we know that any of those have substantial clinical benefits in trials yet?
No. Not yet.
It's just it's a concept that
it's just a concept.
There's an avenue that you can take.
Exactly.
We don't know if it is net beneficial.
Exactly. Then the third group are the group that we call myotropes. And these are the agents that improve cardiac function by directly influencing the cardiac sarcomere. And omecamtiv.
So how do you do that? Because the only way I know is by injecting calcium, and that's the traditional way. That's how God intended us.
Exactly, and that is the calcitropic mechanism that has resulted in over 100 agents that have failed. So there are over 100 calcitropes that have been developed and have failed, and almost all of them have resulted in increased mortality, which is why they took this completely different approach. And I have to give a shout out to Dr. Fady Malik, who is really instrumental in moving this whole field forward in this direction by developing omecamtiv mecarbil, which is a cardiac myosin activator, a very catchy phrase. But this agent actually works on the chemical mechanical cycle of myosin as it interacts with actin. And myosin,
so this is the thick and thin filaments.
Exactly. So myosin will cleave ATP and cock and get ready to interact with the actin filament, the rope, if you will. So the actin's a rope and the myosin head is a hand. And what omecamtiv mecarbil does is it prepares more of the myosin heads to actually be able to grab onto the rope and pull. So
and it does this without increasing intracellular calcium?
With no increase in intracellular calcium, no increase in myocardial oxygen demand, no increase in arrhythmias, no increase in ischemia, all of that data from the preclinical and early clinical studies. So it's a completely unique mechanism of action. It's quite fascinating.
Okay, that's very exciting. Can I take you on to the results of the study? Just give us a quick outline, the duration of the study and the size.
Sure. So Galactic-HF enrolled 8,256 patients with a mean follow-up of 21.8 months. And the primary endpoint was the time to cardiovascular death or heart failure event. And these patients had EFs less than 35%, NYHA class 2 to 4, and some mildly elevated natriuretic peptides. Another thing that was unique about the study is we enrolled patients, about a quarter of the patients from the inpatient setting and the rest of the patients from the outpatient setting, and allowed patients with blood pressures down to 85 millimeters mercury into the trial.
Now that's very interesting, because so often in the ACE inhibitors and beta blockers, when we are starting them, people get scared starting them people with low blood pressures. Whereas if you look at the stratified results of the trials, the people with the lowest blood pressures are the sickest, and they have the most absolute amount to gain. But we get scared because the trials set entry targets that you had to be above 100 systolic, etc. And we actually left out the juiciest people who had the most to gain.
Right.
So well done.
Although, yeah, thank you. So that was one of the debates that we'll get to later on in terms of design of the trial, the tricky things that go on before you do a trial. So
it's important to think and not just do the same as every previous trial. Otherwise, you end up locked into effectively retesting hypotheses that were asked by other people for their own reasons, for their own anxieties. And you should formulate your own anxieties.
Exactly.
The updated ones. So let's look at this graph of the primary endpoint. Can you take us through what you would draw to our attention here?
Sure. So the Galactic HF trial was a positive study for the first time ever, showing that directly improving cardiac function improved cardiovascular outcomes. There's an 8% improvement in the time to heart failure event or cardiovascular death with a p-value of 0.025. And so that met its primary endpoint and was
really good. And I think
really
that's
good.
The kind of, some people might say, well, an 8% relative reduction isn't large. Actually, it is when you have decades of us trying to beat conventional therapy and either having no effect on the primary endpoint or actually making it worse. So this is very impressive. Well done. In what you've just said, you said that it's the first agent to directly improve myocardial contractility. And is that, it took me a while to register in my head, but are you alluding to the fact that when you give someone an ACE inhibitor or other arterial vasodilator, you'll get kind of a secondary increase in ejection fraction, which is not caused by a direct effect on the myocardium? But actually, this is a thing where you directly act on the myocardium and have a favorable effect on measured cardiac function. And this is the thing that does the benefit. All the other things that work directly do not work.
This is the first time that we've actually had something that directly worked on the myocardium and doesn't have any vascular effects. It doesn't have any effect on the channels in terms of rhythm or calcium fluxes or any of the other receptors. So it's purely improving cardiac function.
So this was the primary endpoint, and you were looking at the composite. Where was this coming from? What was driving this?
So the predominant driver of this improvement in cardiovascular outcomes was the decrease in heart failure events. And this was equally spread across whether you were hospitalized for heart failure or had an urgent heart failure visit to the emergency room, or outpatient intravenous diuretics for unplanned heart failure decompensation.
And now this is an interesting situation. I'm looking at the slide that decomposes the two components, the cardiovascular death and the first heart failure event. And my initial reaction is there must be something funny with the arithmetic because each is not statistically significant itself. In particular, the one that was doing the driving doesn't seem to be statistically significant. And yet when you have the composite endpoint, it becomes significant. Is that something you noticed and thought about?
Oh, yes. And that is the difference between, so what you're actually not seeing there is the true components of the endpoint, which are the time to first heart failure event and time to first cardiovascular death. That's part of the, right? So the endpoint is driven by which event comes first, whereas the curve that you're looking at, which is the figure suggesting the overall cardiovascular death rate, which is not significantly different. So so that's the difference, and that's a known aspect of when you do time to event analyses with competing risks. But I think the main message to bring across is that the driver of this endpoint was predominantly the heart failure events. And most importantly, for the first time ever, we have a drug that improved cardiovascular performance without killing people.
Absolutely.
So,
Absolutely. And so tell me about renal effects, and blood pressure effects, which are normally the thing that cause panic and, you know, become dose limiting.
Right, and this is, I think, another very important distinguishing characteristic of omecamtiv mecarbil in GALACTIC-HF, as well as the entire program. There was no effect on blood pressure. And so this agent can be given pretty much any time as you're getting up, you know, the other 4 pillars, if you will, of heart failure therapy. There was also no effect on potassium,
That's very important, yeah.
And no effect on renal function. And so once again, it can be added at any time during the initiation or up titration of other agents.
How would it be that it improves cardiac function and does not increase blood pressure or increase renal function if a lot of these people have renal dysfunction secondary to low cardiac output? How can you explain that?
Well, I think one of the things that we've learned in heart failure, in the relationship between renal dysfunction and heart failure, is that most of the renal dysfunction is actually not driven by low cardiac output. It's usually driven more by renal congestion and intrinsic renal disease. And so in GALACTIC-HF, we allowed patients with eGFRs down to 20, which is lower than in most trials. And most of those patients had significant intrinsic renal disease that's, we believe, is independent of their cardiac function. And so we were very pleased and important to stress that there was no decrease in that function during the course of the trial.
And so that's actually very good. So if I had a patient in principle, and I was thinking about giving omecamtiv, what is it that I would be reflexly needing to check in my mind, in the same way that I would check for, you know, potassium and creatinine for ACE inhibitors?
Yeah, nothing, except, you know, the only thing actually, so the only thing is what we did do in GALACTIC-HF, we did do pharmacokinetically guided dosing. So there were 2 blood tests to measure plasma levels. And so this is actually a tool that, you know, the physicians could potentially use to ensure that the plasma concentrations that they're giving to their patient are the plasma concentrations that are appropriate for that patient and that. But
you know what I'm going to say now, though? You know what I'm going to say.
Go ahead.
Sounds like digoxin. You know, you made me say that.
You know,
made me say that by
you're
having
killing me. You're killing. So, so first of all, digoxin actually works through multiple mechanisms other than improving cardiac performance. There's a lot of debate whether it actually is improves cardiac function. That being said, it also increases calcium fluxes, which is why I think you noticed that in the DIGE trial there was that increase in mortality with the higher doses. And so it is an agent that I think has largely fallen out of favor due to its
So in Europe, it's not used routinely in sinus rhythm at all.
Right.
Sometimes we see it mentioned in North American papers as though it was a routine thing, but it's not a commonly used thing in Europe.
Yeah.
So so what's nice about this is you avoid also and I guess digoxin is a member of the general class, isn't it, of the calcium mediated, the calcitropes, is it?
Yes, if you have to put it there, yes, that would be, if it's inotropic
in one of those 3.
Is in the calcitropic area, yes.
Okay, this is really good. So going back to one thing you said earlier, that I remember in the early days, people were saying that when you give people omecamtiv, it worked by extending the duration of systole. I understand that now we don't think of it as the mechanism of it anymore.
Well, so Darrel, that's great. And, you know, obviously your early experience with John Cleland is shining through here. So yes, the omecamtiv mecarbil, its pharmacodynamic kind of hallmark, if you will, is this increase in systolic ejection time. Now, for those of you who know the literature from 1960s, know very well, right?
Yes.
Which I think
While I
excludes.
was a twinkle in the milkman's eye, yes.
Exactly. But in that literature, they showed that patients with heart failure actually had shortened systolic ejection times. And that correlated with how severe their heart failure was. So the more severe their heart failure was, the shorter their systolic ejection time became. So what omecamtiv mecarbil may be considered doing is actually normalizing or moving towards normal the systolic ejection time. The change in systolic ejection time is 25 milliseconds, which is, so it's not that much. But
do you get problems with people with ischemia where, because you inevitably shorten the diastole by the same amount?
So there are three kind of ways to address that really good question. One, when we actually measured systolic ejection times, and it measured actually diastolic filling times in the Cosmic HF trial, which was the trial that led up to Galactic HF, there was no difference because omecamtiv mecarbil has a mild, because of sympathetic withdrawal, omecamtiv mecarbil actually has a mild increase or decrease in the heart rate, which actually increases the cycling.
It's like a tax refund. It slightly pays back. Yeah.
Exactly. So that's number one. We actually don't shorten diastolic filling time. Number two, we actually did a study, and Barry Greenberg led this study, where we took patients with ischemic cardiomyopathy, with exercise-induced angina, gave them omecamtiv mecarbil, put them on a treadmill first, saw how long they could go. Then we gave them omecamtiv mecarbil, put them on the treadmill again, and there was no difference in their incidence of angina, of coming on, even though now that was in the presence of omecamtiv mecarbil. Then the third thing is, actually in Galactic HF, if anything, the patients with ischemic heart disease, and this is subgroup analysis where the confidence intervals are overlapping, so I'm not making a definitive statement here, but certainly, if anything, the patients with ischemic cardiomyopathies did a little better. So I think hopefully and that's actually why it was important to show that there's no difference in cardiovascular death. We adjudicated myocardial ischemic events and myocardial infarctions in Galactic HF, no difference compared to placebo. And one of the most common findings in all of our studies is the adverse event profile of omecamtiv is similar to, if not identical to, placebo during all these studies. So
that's really good.
Yeah, with 15,000 plus patient year experience in Galactic HF. So
that's amazing. Well, it's very exciting. Do you have a feel for what would be needed for this omecamtiv to become enter guidelines, get to that level of familiarity?
Well, so the first step is obviously, for many guidelines, they can't talk about a drug until it's been regulatorily approved.
Of course.
So that's going to be the first step. And I think one of the things that we've really only had these data for weeks. So we're still trying to work through all of the intricacies of it. A common theme is emerging, which is that while the overall study was positive with this 8% reduction, if you look at patients who had ejection fractions less than 28% or equal to, they had a 16% improvement in the composite outcome. And if you look at and once again, if you look at the subgroup analyses, with all the caveats of looking at subgroup analyses, we have to be careful. But in all of the kind of sicker patient populations for the New York Heart Association class 3-4, the lower blood pressure, the inpatients, the folks that were had sicker heart or more advanced heart failure, they tended to do better. So one of the real, I think, opportunities for omecamtiv mecarbil is that in the patients where there is a little more advanced heart failure, it should, because it doesn't have an effect on blood pressure, renal function, potassium, any of these things.
Because those are the very patients in which you're going to be stuck because of all of those problems.
You can add it there readily. And so I anticipate that will be the way into guidelines and in practical use. I think, the good news about this is I think it's a drug that actually can be used. But we'll see.
It's fantastic. It's really good, and it's the lack of side effects is not because you haven't tried it enough people. You randomized thousands and thousands and thousands of people.
It does go along with some of the concept of that the atria actually have cardiac myosin as well. And it's the same cardiac myosin.
Yeah. Oh, I
And
see.
so, yeah,
And it might be stabilizing rhythm.
exactly. And in atomic AHF, which was the acute heart failure study, we actually saw a decrease or less increase in atrial fibrillation in the omecamtiv mecarbil treated patients. In galactic HF, this 8,000 plus patient trial, based on the sloppy adverse event reporting, the numbers of adverse events for atrial fibrillation and atrial flutter are actually less. So it's an intriguing, I'm not going out there. I don't want to get arrested for this.
No,
but
no,
there's
yeah.
some
But
intriguing.
in fact, as fellows are watching, this is what's called hypothesis generating.
Exactly.
You look at something and say, hang on. So now the next trial you do, you're going to really suck dry the rhythm to really look hard for it, by doing halters systematically or even implanting a loop recorder to give a chance to get as precise information as you can on this, because it's going to really annoy the electrophysiologist that if you find something that saves them.
I don't have a trouble annoying my electrophysiology colleagues. I like them very much, but I'm okay with annoying them a little.
No, the best way to annoy them is to go into the EP lab when they've been there for like 3 hours ablating away, and then point at the screen and say, I know what you need here, amiodarone, and then run away.
Yes. They have locked the EP lab to me, so I'm not allowed to go in there. Anyway.
Well, this is fantastic. Really, really good to have you on the show. And we look forward with great interest to this coming into our hands for clinical use. So thank you very much, John Teerlink.
Brilliant. Thank you, Darrell. This has been great.